Now, I will talk on acute monoarthritis. Acute monoarthritis is acute inflammatory process that develops in a single joint over a course of few days and less than 2 weeks. Common causes of acute monoarthritis are avascular necrosis of bone, crystal-induced arthropathy, hemarthrosis, infectious arthritis, traumatic arthritis, overuse. Less common causes are malignancy, psoriatic arthritis, rheumatoid arthritis, and very rare causes are amyloidosis, Behcet's syndrome, familial Mediterranean fever. These are the less common causes. Coming to the workup and approach to the patient. Many joint disorders initially can produce pain and swelling in a single joint. Since missing important joint disorders such as septic arthritis can cause significant morbidity and mortality, an appropriate approach to the diagnostic workup must be made. If taken rightly, you may get burnt and cause a patient serious harm and lifelong consequences. This is the diagnostic approach to the acute monoarthritis. First, you have to take a complete history and physical examination, then rule out the soft tissue problems around the joint, then take a proper history about pain, fever, all things, do an appropriate investigations like imaging and blood tests. Coming to the history taking, establishing the chronology of symptoms is very important. Rapid onset over hours to days usually indicates an infection or a crystal induced process. Fungal or mycobacterial infections usually have an indolent and protracted course but can mimic bacterial arthritis. In history, you have to take about the history of trauma. Even with no trauma, if they have osteoarthritis, still may have a traumatic injury, or there other joints involved, or there any penetrating injuries, sexual history and history of illegal drug use, alcohol use, travel, tick bite should be ascertained. In the history, look for the risk factors. A prospective 3-year study found that the most important risk factor for septic arthritis are prosthetic hip or knee joint, skin infection, joint surgery, rheumatoid arthritis, age greater than 80 years, and diabetes mellitus. In the history, we'll get some clues, diagnostic clues in patients presenting with a joint pain. Sudden onset of pain in a seconds or minutes. It is usually seen in fractures, internal derangement, trauma, or loose body. Onset of pain over several hours or 1 or 2 days. Infection, crystal deposition disease, or other inflammatory arthritic condition. Insidious onset of pain over days to weeks. Indolent infection, osteoarthritis, infiltrative disease, or a tumor. Intravenous drug use, immunosuppression, septic arthritis. Previous acute attacks in any joint with a spontaneous resolution, crystal deposition disease, other inflammatory arthritic condition. Recent prolonged course of corticosteroid therapy, infection, avascular necrosis. Coagulopathy or use of anticoagulants, hemarthrosis is possibility. Urethritis, conjunctivitis, diarrhea, and rash, then think of reactive arthritis. You have to see the skin. Psoriatic patches or nail changes such as pitting, then psoriatic arthritis is possibility. Use of diuretics, presence of a tophi, history of renal stones or alcohol abuse, then think of gout. Eye inflammation, low back pain, think of ankylosing spondylitis. Young adulthood, migratory polyarthralgia, inflammation of the tendons of hand and feet, dermatitis, then gonococcal arthritis. Hilar adenopathy, erythema nodosum, then possibility of sarcoidosis. That's all about history. Then we'll discuss about physical examination. In physical examination, you have to determine whether the source of pain is the joint or a periarticular soft tissue structure. Simple range of motion test can give greater insight. True intra-articular problems cause restrictions to active and passive range of motion, whereas periarticular problems restrict active range of motion more than passive range of motion. Septic knee will hurt no matter which way you move it or touch it, whereas a sprain will only hurt in certain directions or under stress. Next step is doing an X-ray of the joint. You have to epilateral of the joint and include one joint above and one joint below and the diaphysis of the bones. Sometimes septic osteomyelitis of the bone can cause effusion of the joint and patient may have pain in the joint. If the results show fracture or avulsion, then manage according to the severity. If the results show osteoarthritis or chondrocalcinosis, you no longer are changing a dramatic cause of the monoarthritis and you must look further. You have taken complete history, have ruled out the soft tissue injuries, have done X-ray, X-ray is normal. Now your blood test investigations are ready. If CBC, uric acid, and ESR or general screens lead us to further. High WBC may be infection or a chronic inflammation. High uric acid may be a gout. High ESR arthritis exacerbation may be possibility. Is it a septic joint now? Blood culture should be obtained in a patients with a suspected septic arthritis. However, cultures are positive only in about 50% of non-gonococcal infections, but rarely positive in gonococcal infections. It is only 10% in gonococcal infection. Don't let negative blood cultures throw you off the septic joint track. Don't wait for report. Start a broad spectrum antibiotics after sending blood for the culture and doing basic investigations. Don't wait for culture report. Now we have done all the basic workup, including excluding the other soft tissue injuries. You have done X-ray and blood test, and now you are with the blood test report, which are almost normal. Now you have to think about doing a joint aspiration. If there is even slight suspicion that this might be an infectious cause, a tap is a mandatory. If there is no effusion and there is still suspicion that the patient has a septic arthritis, then do a CT guided or ultrasound guided aspiration of the aspiration of the joint. After sending the fluid for the culture, start the antibiotic in the emergency department only. Don't wait for the report. Tapping the knee. Synovial fluid should be sent for white cell count with a differential, crystal analysis, gram staining, and culture. Superimposed cellulitis is a relative contraindication to arthrocentesis. Can be performed safely in patients who are taking warfarin. The warfarin intake is not a contraindication for joint aspiration. Removal of as much synovial fluid as possible offers a symptomatic relief and helps to control infection. Until infection has been ruled out, corticosteroids should not be injected into the joint. If the aspiration is a frank pass, don't wait for the culture. Take the patient to the operation theatre, thoroughly wash the joint and start the medicines and send the fluid for the culture and send. If the aspiration is clear or shows a large fat droplets and it is not turbulent, it is not turbulent, it is not a pus. If it shows a large fat droplets, then it indicates bone trauma and damage and you manage it as a joint injury. You have to send all aspirations for the culture and sensitivity. If culture shows suspicion of infection or infection, then give antibiotics. If the aspiration is bloody, occult fracture or internal derangement or tumor is a possibility, do an MRI scan or arthroscopy. If the joint aspiration shows crystals, if positively bifurcent in polarized light and needle-like crystals are seen, then the diagnosis of arthritis can be made. If negatively bifringent crystals are seen, pseudo-gout is the possibility. Along with the crystals, there will be an inflammatory WBC and much less segments and much lower WBC than the septic culture would have. However, the finding of crystals does not exclude the diagnosis of septic arthritis. If the aspirated fluid is transparent, WBC count less than 2000, we can now consider these non-inflammatory conditions and make the appropriate therapeutic decisions. The non-inflammatory conditions are osteoarthritis, trauma, vascular necrosis, Charcot's arthropathy, hemochromatosis, pigmented villonodular synovitis. If arthrocentesis shows more than 2000 WBCs, then possibility is inflammatory arthritis. With this type of numbers, the following could be possibilities: SLE, Lyme disease, spondyloarthropathy, rheumatoid arthritis, reactive arthritis. If aspiration is opaque fluid or a frank pus, WBC count more than 75,000 or more than 70% are white blood counts, or a WBC more than 1 lakh is an infection until proven otherwise. With these results, appropriate management should be initiated without waiting for other reports. Coming to the conclusion, in acute monoarthritis, septic arthritis is the worst case with the worst outcomes. Therefore, you should assume it is until you have reached a threshold to rule it out. Roll out septic joint first. Start antibiotics. Don't wait for the culture reports.